Hello friends, welcome to
Hello.
another interview in National Update on Clinical Diabetes 2021, NUCD 2021. Today we are talking about with a very important person who is deeply involved in the science of insulin, and since we have already passed 100 years of insulin discovery and a lot of things have happened during these 100 years, it will be very interesting to know from the people and the group of people, those who are extremely involved, beneficial to the humanity, and they have produced best insulins to help mankind. Along with me is Dr. Deniz Tutkunkardas, who is from Novo Nordisk, Denmark. Welcome, Deniz.
Thank you so much for having me. I'm so excited to be here.
Yes. So, 100 years have passed after Benting and Best discovered insulin. So many changes took place, so many developments in the molecule. The only molecule which attracted largest number of uh, Nobel Prizes, and it has become a part of every diabetic for last 100 years. So we'll start on the past 100 years of insulin. In last 100 years, what would you say there are main inflection points that sparked quantum leaps in the development of insulin from the days of Banting and Best to present day?
I think when we think about the leaps in the insulin for the past 100 years, there are many things that we actually don't even think about at this stage because it's such a different place compared to 100 years ago. Back in the days, if you remember the glucose profiles of the patients that were given insulin, it varied a lot. And I think the purification of insulin from the pancreas was one of the first things to make it very pure, or at least close to very pure. That was the first leap. I think then came the recombinant insulin when we started using yeast and bacteria to purify or to produce insulin. That was, I would say, the second leap. And then to make an insulin that is shorter, that would best fit for a prandial insulin, and a quest to make it even longer to make it fit for a basal insulin was the other leap. So to make it a longer one, I would say NPH was the first leap. And of course, there were some more trials with the lenta or ultra lenta insulin that is not there today, but even the quest was there. And then, of course, came the basal analogs, there came the prandial analogs, and now we're working even to make those more optimal by either making them even longer or even shorter. And on top of that, of course, there were the technological advancements, like first of all, the glucose measurements. I mean, coming from the urine sticks to the blood glucose measurements, and now we have the continuous blood glucose measurements, the CGMs, that can even give alarms to the patients when something is going wrong or something is wrong. So, and this is not even the end. There are going to be many, many leaps, hopefully, in the future.
Yes, Danish. Do you think the modern day insulin that we are using today are the near perfect? Are they near perfect? Or is there any scope for them to be more perfect in the future? Any research on that?
I think, as I said, we have come a long way from the very beginning. We're doing quite well with the insulins, but I would say we're not there yet. We are, I would say, far away from being perfect. Even though we have amazing products today, still insulins have a very narrow therapeutic range, and it can induce hypoglycemia if the patients are overdosed. It still causes weight gain as a part of the profile of the insulin, hence negative side effects. So I would say we have some leaps that are awaiting us. For example, if we have an insulin that stops working in the hypoglycemia range, meaning that it would not give any hypos, that would be another leap. If we have an insulin that causes no weight gain at all, that would be another leap. If we have an insulin that covers both the basal requirement and the prandial requirement at the same time, with only one injection a day, or maybe even less, that would be another leap. If we have an oral insulin that the patients don't have to take injections anymore, that would be another leap, I would say. And If we have technological improvement to the devices and to the closed loop systems that would further improve the patient's life, I think that would be a leap. So we're at a quite well stage, but we have still a lot of things to do in the future.
But when body produces insulin, it doesn't produce 3 types, 4 types of insulin.
That's so true.
Same insulin works at different times of need. So there is some gap between understanding the insulin action and the physiological behavior of the body. And once we match that, as you have rightly told, 5-7 factors are involved. So that will be a great thing in future insulin treatment. How do you think that our quest for prandial insulin is going on?
That is also, I think, we have also come a long way with the prandial insulins. We have made them shorter acting and also faster acting. And now we have even faster analogs in the market, in many, many markets. But they, of course, can be faster. But when you look at it from another perspective, I think with the prandial insulin, there's also the element of the technology and what the devices can do in terms of prandial glycemic control management. We can have, or we already have, automated closed loop systems which can be further improved and further given to the patient, so that they can adjust themselves automatically to the prandial requirements of different carbohydrate to fat content of the meal, so that they can have an extended duration if necessary, or they can have a very short and crisp duration if necessary. Of course, the analogs have to be adjusted slightly, but the technology has to come with that as well. And in addition to that, we can also, of course, improve the dual hormone closed loop systems, which is not there. It's on its way, with also the glucagon, and that can be another way. So there are a few things also in the horizon, I would say, and a few things that need to be done also in the fast-acting insulin space.
Deniz, in most of the research, from research desk to the bedside, it takes a long time. And many of the advantages that we get in research is not clinically available to the lowest of the low people, or those who cannot, in developing countries and like that. So what do you think that common people, common patients will get these advantages? What is the time limit?
I think that's an important question to answer with the availability of our products to many patients. Of course, Novo Nordisk is trying to initiate or support many of the availability programs that we can reach the majority of the patients, or to as many patients as we have as necessary. I think, of course, pricing of these products still are an issue. We're doing our best to overcome these, but I think there needs to be more. There needs to be more work done with regards to pricing, and then we can get it to as many people as possible.
Great. We find IDEG-ASP and IDEG-LIRA combinations, co-formulations, and they have given a big armamentarium to the physicians and diabetologists and endocrinologists to prescribe. How do you think about this product, and how exciting it is in the market? How do you think? What is your opinion about that? Co-formulations.
Yeah. I think the funny thing is that degludec was first designed as a basal insulin that was there to be combined with other products. So the first reason that degludec was created was that so that it could be combined with insulin aspart. And now we have two products that are combination products, as you mentioned, one of them being IDEG-ASP and the other one being IDEG-LIRA. And I think for IDEG-ASP, it nicely covers the prandial requirement of a patient, in addition to providing a very flat and stable basal insulin, and meaning that the patients can inject safely without having the shoulder effect of, say, a premixed insulin, and with convenience, just not have to, they don't have to inject both a prandial and a basal insulin. And for IDEG-LIRA, I would say it has shown in their clinical trials that one injection of IDEG-LIRA can provide glycemic control of a basal bolus regimen, of a full basal bolus regimen with no weight gain, and on top of that, of course, very low risk of hypoglycemia. So from a convenience perspective, finger sticks, the number of injections given, or forgetting a little bit more about diabetes and focusing on your life, I think these products add a lot of value to the physicians as well as to the patients to overcome the hurdles of some of the hurdles of diabetes.
They are really helping for the obese people to reduce body weight. Hypoglycemia is less, and control becomes much easier with these co-formulations. So we are happy that such a product is available. But the second thing is regarding fast-acting aspart. When aspart was there, everybody was happy that such a very fast-acting insulin is available for prandial control and all those things. Then came the fears, and that is still closer to human pattern, physiology pattern, but still there is a gap. What do you think? When do we match that gap and that becomes almost human?
I think that's a very good point, and we still have some time to match that gap because we need even faster insulins. Because as I try to say, but for example, automated closed loop systems or in systems that you don't need patient interaction, the insulin has to start acting almost the minute that the sensor reads that there's an increase in the blood glucose levels. So we're closer to what is there, but I think there is still some time for improvement. So
And
it will, hopefully it will come in the future, but we're not there. I totally agree with you that we're not there yet.
We're not there yet.
No.
There is now, previously we were looking at control as glycemic index. Now time in range has come. Glycemic variability is a bigger point of discussion to assess the metabolic control and all those things. So what do you think about glycemic variability and time in range aspect of these newer insulins?
I think it's a very important topic, and I would say time in range or the CGM derived parameters is the new black. Many people are talking about it, and many people are interested in it for the very right reasons. I think A1C is of course cheaper, but it doesn't provide all of the details of glycemic control of a patient. And time in range and all CGM derived parameters provide an overall a nice overview of the glycemic control. I think when we look at the basal analogs that we have today, we have improved time in range with degludec, for example, versus Glargine 100, and we have improved nocturnal time below range again with degludec versus Glargine 100. But when you move from time in range or from the CGM parameters more to the glycemic variability, it becomes a little more difficult. We know that in the CLAMP studies, under optimal conditions in the laboratories, we can show that the newer analogs have better glycemic variability. But when we then translate or try to translate that to the CGM-derived glycemic variability, we cannot see that. We think that it might be due to the patient difference because they are not under optimal conditions. If they have a lower glucose, they take action against it. If they have a higher glucose, they take action against it. So it's a human factor. So we don't see the glycemic variability as a prominent feature in our basal analogs when it comes to the CGM-derived parameters.
Right. That means we are yet to understand the physiology in the human body perfectly well, so that we design a product to match that physiology. So
true.
We have to do more research on that. My patients sometimes ask that, is there any new method of giving insulins and injections, and can it be painless or can it be longer duration? And what Novo Nordisk is planning for any such thing?
Yeah, and I think when we look at the GLP-1 analogs, they have come a long way from a daily injection to a weekly injection, and that's what we are thinking. We think that a weekly insulin injection, a basal insulin injection, could save a lot of patients' time and effort. So we're currently developing a basal insulin analog that has a half-life of around 7 days, so it can be injected once a week. So we think that it's going to help many patients to initiate insulin, and it would make the life a lot easier for patients that are already treated with an insulin to switch to this, saving them many injections over the course of years. And of course, on top of that, a combination of that insulin with, say, semaglutide can also offer even more value to the patients that need further intensification. So we're in the pipeline, we're working on a few projects.
Many people want to take insulin. Many doctors also want to give insulin. But this pain factor, pain means the suffering factor, inhibits people to take insulin. So that has to be developed much faster and in a different, so that insulin, we all know insulin is the treatment for diabetes, and we should try to achieve that goal. Do you foresee, there's a different type of question I am going to ask, a scientist and all. We now get insulin from pancreas. Is there any other future source in the human body itself which we can tap to get insulin from other parts of the human body?
Yeah, I think maybe to answer it in a slightly different way, there's a lot of research going on with beta cell replacement. And those are coming mainly from stem cells, from various different sources. They can be body's own stem cells. They can be stem cells coming from other donors, from other sources. But there's a lot of research going into making another resource that the body can produce. This has to be given externally. It's not something that we can tap on, but there is research with the stem cells. It is not the easiest quest, I would say. It takes a lot of research, a lot of effort to make sure that it is safe, to make sure that those cells are also not destroyed like the body destroyed in the first place. So they need to be protected from the immune system. So there's a lot to be done, but I would say that a lot of research is going on, and hopefully one day this is going to be the savior of especially the type 1 patients that are so dependent on insulin.
There will be microcapsules and all those things will come up.
Yeah.
That will become a reality when we can inject one dose and the living beta cells can circulate in the body and go on producing insulin, and other things are there. As clinicians, as doctors, we always see that you have produced FIASP, you have produced degludec, you have produced many other molecules. But what is the research and torture or problem behind a drug development? My viewers would like to listen to you quickly.
It takes a long time for a medication to come to the market. And in the background, there's a lot of trial and error. It's basically very, very hard process where we just try and changing it slightly this way or slightly that way. And there's a lot of knowledge about what a single modification can do to the product. But I think the most important thing that is behind that is the imagination of the scientist and the needs of the patients. Because if we don't think what the patient needs, we would never get to that. If we don't think that a weekly insulin, for example, can improve a patient's life, we would never search for it. Or the same applies to various other insulin products. So I think what it takes the most is the imagination of the scientist and the need of the patients, and putting themselves in the shoes of the patients to think more, and of course interactions with the physicians to see what they need from us.
Deniz, now you must have heard that you know that there is a reversal of type 2 diabetes is a new concept. All over the world, people are working on that, in India also. And in that situation, if that becomes a regular practice, how do you find the role of insulin after 50 years or 100 years? I
think that's also a very, very important question to answer. As I said in the beginning, insulins have a very narrow therapeutic index with also side effects that are unwanted. But if we can find an insulin that almost doesn't give hypoglycemia and or that doesn't cause, say, weight gain, I think it will have an important role in reducing the A1C, say, to the normal level, so that the patients don't even have to think about their diabetes and live safely. But we have some time until then, and maybe up until that is done, other medications that we have in the market would have to take the lead on it. But until insulin catches up with that, with the safety profile.
Thank you, Deniz. It was very interesting to listen to you, the man who is in charge of novel insulins at Novo Nordisk, Denmark. And my viewers must have enjoyed it. And at NUCD, we will expect you in coming years with more information, more data, and all the best from India. Thank you.
Thank you so much for having me and looking forward.
Thank you. Thank you so much.